Yeah. So that's really interesting that the patients are divided into that the group that wants to fight and the other group that's not in as much.
Because unfortunately the prognosis is very poor, and the efficacy of drugs, because we talk about non-GIST, not that great.
Yeah.
For some form of more indolent, if there's loudmouth sarcoma, epithelial sarcoma from the ovary, tamoxifen might work a little bit, but in majority cases, we're not that lucky.
Yeah.
Even we use TKIs, you go, 6-7 months a run, and then they blow through it. So younger patients are more willing to say, okay, I tough it out, I try. But older people, after 1 or 2, they say, forget it, leave me alone.
So you kind of set up the situation I was going to ask you about. What's that like for you as the oncologist? You have a patient sitting in front of you who wants to fight, and yet you know that, your options are limited, this patient's not going to get cured. What's going on with you during this as the oncologist?
Yeah, I mean, we're all human. Mm-hmm. Cannot hide my emotional response, just like anyone else. I'm entitled to it. But in the end, I'm a professional. I'm an oncologist. Being optimistic is really one of the very special, unique features of oncologists. Mm-hmm. If we were not optimistic, we wouldn't be here today, 30, 40 years ago when there's only 5 FU. I know how people build the stigma about oncologists, but we're not there anymore. So as long as the patient is willing, I think one have to keep going and keep doing research, clinical trial, and carry that into clinical practice. Mm-hmm. It's a team effort. Today's effort is never going to be wasted because someone else will benefit from it.
Mm-hmm. So when these patients come in, what's their goal? What do they expect from you and from
they?
treatment?
I think, especially in the first line setting, they all have the goal that they can have it cure, despite the fact that we're discussing incurable. But they want it to be cured. Mm-hmm. They want to live longer. They want to win this battle. And that is, even for the elderly, I mean, the key thing is first time they come in, especially seeking a oncology consult, why would they come if they didn't think there's a possibility? Mm-hmm. So the back of their mind is they all believe they can control it and do something about it. Of course, the discussion might clarify some issues and set the expectation to a more realistic level. But that's everyone's goal still, It may not be reachable, but it's okay.
Yeah, so how do you deal with that? If the goal is not reachable and patients are looking for that, what
I have to emphasize the point that incurable is incurable. Mm-hmm. There are certainly treatment options that, based on past experience, can control it and even cause regression of the tumor. Mm-hmm. But we can never forget that the disease certainly have a very good chance that will resurface. And when it does, we will deal with it. But I do not give false hope or false expectation, because it will come back to bite you. Mm-hmm. It will just make the second part of the discussion more difficult. So might as well be honest from the get-go.
Yeah. How do the patients respond to your honesty?
Actually, they're pretty good. No one is happy to hear the truth, but they are not dumb. One of my patients, it was totally different. Have lung cancer. It's like, why you switch to see me instead of the other? The doctor says she could cure me and let me live for like 7 years. He's like, forget it. He's just not telling me the truth. I better move. So, and also there have been research done as a clinician with a go for those CME credit. We learned that patients expect just cut to the chase, very clear, tell them what it is. But of course, you want to be a bit sensitive, but just tell them, this is what it is. We're dealing with it. Let's not move on, instead of just sugarcoat it too much. Mm-hmm.
So what are your treatment goals for the patient?
Certainly, I would expect some kind of response to shrink the tumor, not to totally make it disappear, complete response, but shrinking it can lead to improvement of symptoms and quality of life. Sarcoma, soft tissue sarcoma is a solid tumor. Symptoms are related to structural situation, meaning pain, or difficulty breathing, or cough, or disfiguring, anything. So able to cause some kind of tumor response will always help the patient.
Yeah. So tumor response, you look for in
some kind of partial response, or at least shrinkage. Yes.
Extended survival or survival benefit? Are you?
Yes. Disease-free survival is the minimal. Overall survival is something, I'm not keeping track exactly where we were 10 years ago and now, but we are marching forward when we have more than one line of treatments, more than one agent. Our patients do live a bit longer, and with all those TKIs that we have. So I think it's not unreasonable to ask for that to be a possible goal. But unfortunately, my definition of improving survival certainly can never match up with patient expectation, right? To us as a doctor, a overall survival of 2 months improvement, we look at it as celebration. Let's make a toast. Patient look at me and like, 2 months, doc, what the heck you talking about? I'm only like 35. 2 months is nothing. So I think we hopefully can be much closer one day in terms of the way how we celebrate so-called survival benefit.
Yeah. Is your treatment approach or your treatment choice affected by whether the patient has critical symptoms?
Somehow it has to be. Certainly a patient much more aggressive, sicker, they would benefit from systemic chemotherapy versus if they're more indolent type of histology and relatively not as asymptomatic, we can negotiate, quote unquote. I would say yes, some, but cannot be the only reason. The major determinant of what to use is still depends on the histology. And of course the patient performance status, comorbidities, etc., tolerance.
So that drives most of it. We talked about these patients who really want to fight on. Does that ever affect your treatment choice?
Initially, yeah. It just make the ability to use a multi-drug regimen more justified, and so-called bite the bullet with the toxicity of ifosfamide, doxorubicin, high-dose cyclophosphamide, etc. When I see the patient with potential neurological or hematologic toxicity, you hang in there with the patient because hopefully you ride through the big wave and you can go to the calm water after 2-3 months and kind of regroup yourself and see where we stand.
So we're going to talk more about the specific treatments, regimens later, but I was just curious when we were talking about this type of patient, the non-curative, etc. What is your preferred regimen? Do you have?
Well, the first line, usually systemic chemotherapy, often will be doxorubicin, ifosfamide, or gemcitabine with taxotere, but circulating around that, depending on the type of histology, the regimens, the patient tolerability. If the patient ever had anything in the not adjuvant, but in the early stage, the story could be a bit more complicated. But those are the agents often you pick and choose to create your cocktail.
Okay. So as I said, we're going to talk more about those in a little bit. You mentioned a term earlier when we were talking about, I think you said aggressive, how aggressive the disease is. Was it aggressive in terms of the disease? Tell me about that. When you hear aggressive disease, particularly in the context of non-curable first-line soft tissue sarcoma. What does that mean to you, aggressive disease?
Sad.